For more than 3 decades, the field of organ transplantation has made great strides, not just in great outcomes, and saving thousands of lives with patients having end-stage organ disease. However, improved techniques, new anti-rejection drugs have played a fundamentally large role in providing this level of success. Yet with all these advancements, the waiting list of patients awaiting transplantation remains long, outpaces the number of donations. Organs continue to be a scarce resource. However, there are many recent innovations, not just in technology, but many new fields that have turned up and probably seem to address the unending, unmet need for organs. The field of biomedical engineering stands foremost among all of it. My attempt is to probably throw light on a few of these technologies. We'll probably help you understand it better. The challenge truly continues to be the fact that to simplify a lot of this very high-end technology is not easy in a couple of slides. I hope you will all bear with me and give me a moment of time and your attention to be able to unravel a little bit of it. So our current challenges, as I said, we have a serious demand-supply mismatch. We have extended criteria donors who are not really suitable donors for organ transplantation. We have a universal lack of standardized donor management. Though we have great guidelines, I do not think we have reached a point where donor management is standard across most donor hospitals all across the world, not just in India. We have a problem of logistics. We have a problem with geographical remoteness and allocation, which in a country like ours, 25 states, 26 states, everyone has their own set of rules. Likewise, the big challenge continues to be the appearance of multi-drug resistant infections and a rise in the number of pre-sensitized patients. Patients who turn up for transplants generally have had previous surgeries. They have been sensitized to the human antigen simply because of blood transfusions and many other procedures, so on and so forth. They have a high chance of rejection. So figuring a way out is a big challenge. We have sicker patients. We have patients with more comorbidities. So the attempt is to probably try to tell you what is in practice right now, that is the current reality, what the future could be, and I would end it up with talking about the applications of mobile health in transplant outcomes. So I'll start with machine perfusion. And we all know that the success of organ transplantation depends on the quality of the organs. So machine perfusion is something where donor organs are preserved under normothermic or subnormothermic conditions outside the body, allows clinicians more time to not just accurately evaluate donor organ function prior to transplantation. And this has significantly impacted the unmet need for a great number of organ donors. So for that, we need to first understand what are the limitations of the static cold storage paradigm that we use currently. So there are a couple of shortcomings with static cold storage, the most important being that you cannot reverse organ injury. Cold ischemia continues to happen during the period of storage. Organ quality cannot be assessed. So as you extend the times of static cold storage, it leads to cell death due to anoxia, apoptosis, and a deterioration in graft function, which is undetectable till you transplant, and then you figure that the organ isn't working. This is a lovely cartoon which tells you exactly what happens to the cell, but in general, as the level of phosphates, that's the energy substrate, comes down in the cell, there is a rise in cytosolic calcium. There is a great deal of toxic byproducts that accumulate in the cell, leading to swelling, leading to disruption of the cellular membrane integrity, causing apoptosis and death. The challenge with standard static cold storage is this, that you cannot utilize it in DCD hearts or DCD lungs. So that is the great limitation. So unless you address that paradigm, you would never be able to make use of DCD organs or extended criteria organs. So what is the recent advance with static cold storage? This is one such machine. This is called the Paragonix. So what it does, it prevents widespread temperature fluctuations. It prevents direct thermal injury to the organ, which is fairly common when you have cold storage ice utilized to have as a storage material. It eliminates the variability of packaging materials. It prevents the issues related to biocompatibility of the sleeve, and it also prevents tissue injury which is caused by movement or vibration, especially during transportation. Most importantly, extreme cold temperatures cause protein denaturation, and extremely high temperatures obviously increase metabolism, leading to cell death. So how do we make a dent in the organ supply equation? Yes, we know that current machine perfusion allows us to address the issue of logistics. You can put an organ on the machine, allow it to travel faster. It could probably travel easily from Delhi to Chennai, get transplanted. Patient would do well with a organ preservation paradigm. But we have to go a step further. So we can utilize marginal organs now with the utilization of organ care systems, and we can also source donations after circulatory death. So this brings us the challenge of how do we do this? So we are already at this stage where the surgeon's resting, he receives a call from the OR, the patient is ready on the table, and the organ's been reconditioned. So what you're seeing right now is a pair of EVLP lungs and ready for transplantation. So the concept of machine perfusion started in the 1960s, and it was primarily deflected towards thoracic organ transplantation largely because of short ischemia times, 4 to 6 hours, maximum of 8 hours for lungs. So we realized that this could seriously make a dent into the availability of organs as such. There are various perfusion settings, there are various types of pumps that are utilized, either pulsatile or centrifugal type pumps. But all it does is it improves the quality of the organ on offer by using a nutrient hyperoxygenated sanguine solution in many cases. On the heart side, you have normothermic perfusion and OCS systems with the machine that probably everyone has heard about and also seen in video clips. It's called the Transmedics, the heart in the box, which will probably bring a lighter bulb for most of you. It allows the heart to beat in a nearly physiological state. And it has been proven by not just the PROTECT trials in Europe and the PROCEED 1 and 2 trials in the US, it is non-inferior to standard static cold storage organs or hearts. So this has been proven by these trials. So they realized that there was an opportunity for us to go further. Likewise in the lungs, when you utilize standard protection, lungs would do reasonably well because you have a long ischemia time as long as you have a local organ or an organ that can reach you from quite close. But unfortunately, the lung is such an organ which has probably a retrieval rate of as low as 15% in the best conditions. So just 15% is really very low. When you probably look at the West, especially the United States, you need 4,000, you do 4,000 lungs a year, whereas the demand is at least 3 times more than that. So how does machine perfusion help? It helps you reduce the incidence of primary graft dysfunction, which is as much as 30% when you look at lung transplantation. It allows you to extend the distance of transportation. It also now allows you to do organ repair. You can treat patients who have aspirated. You can treat infections in the lung. You could also treat neurogenic edema. Because many times when there's a lot of pulmonary edema, especially after serious brain damage, some of these lungs are termed unusable, but that actually is not the case. In the OCS heart, going forward from the standard criteria donor, there was a trial called the EXPAND trial. So the EXPAND trial, what it did was it took suboptimal hearts that were refused for standard criteria donation, and these were the reasons why they were done. Some of them had arrests in the ICU. Some of them had a long expected ischemia time. The ejection fraction was low. Some of them were older donors with mild coronary artery disease, which was demonstrated. So all of these unused hearts were utilized in nearly 81% of cases on this platform. And the 95% survival rate at 30 days matches those of standard brain death donors, standard criteria organs. Going forward, you could also see that not just the 30-day, but the 90-day and the 1-year survival and the effectiveness, the primary endpoint generally being primary graft dysfunction, was so suitably served that they actually had lesser graft dysfunction than standard brain death standard organs. This took us further towards the DCD trial, so retrieval of hearts and lungs from patients after circulatory death. And this is what it showed. It showed that even at 90 days and 1 year, you probably had comparable outcomes with DCD hearts and lungs as far as this platform was concerned. On the lung side, I'm so sorry, just acting up a bit. The INSPIRE trial showed a non-inferiority of EVLP or Transmedics OCS preserved lungs compared to standard criteria static cold storage. So a non-inferiority allowed us to look at this. it shortened the ischemia time by breaking it down into ischemia time 1 and 2. And the intermediate period, which was the longest period, allowed normothermic, oxygenated, sanguine perfusion. So blood perfusion of the organ, you could do a lot of analysis of that organ that was being accepted for transplantation. So this is the EXPAND trial, which tells you that all of these borderline organs, which were refused for standard donors, standard recipients, showed a 91% survival at the end of 1 year, and a significant reduction in the grade of PGD, 17% compared to what 30% is worldwide accepted standards. The other very unique therapy that is allowing us to make better decisions is the utilization of biomarkers. So if you have point of care testing, you could probably utilize biomarkers to decide which lung to put on the platform. You could decide which lung would perform best after utilization on the platform, and it would also allow you to figure out if you have targeted therapeutics or personalized medicine, as you would call it, on that organ. Would you be able to have biomarkers that will tell you that this lung would really do well in not just the short but even the long term? All of it requires point of care testing. So we are already in the realm at a point in time where these tests and reports will be available to us within 30 minutes after assessing the organ. So the slide on the right-hand side tells you the types of biomarkers that could be, information that could be derived, right from inflammatory markers to damage-associated molecular patterns. This is a bacteriophage that you see on the left-hand side, and a bacteriophage-derived therapy is utilized for patients who have resistant infections. Multi-drug resistant infections in donor organs could be treated with bacteriophage therapy. You could do bronchoscopy on that lung, you could tracheal toilet it, you could use inhaled bronchodilators, you could use topical and systemic antibiotics that cannot be given in high doses simply because you would have either liver or kidney damage, could be given in supratherapeutic doses to just the perfused donor organ. And that could treat the infection in not just the circulation, but even in the airway. Then you have membranes, you have cytokine filters that will allow you to reduce the innate and adaptive immunity burden that would happen once you've transplanted the lung. So the possibilities are limitless. Another massive stride that has happened is the use of mesenchymal cells. So mesenchymal cells are actually multipotent self-renewing cells that happen to reside in your bone marrow. So these cells can avoid trafficking by direct infusion, not just endotracheal, but also into the pulmonary artery directly. It enhances the quality of the organ, it increases the number of usable grafts, and it facilitates their acceptance post-transplant. So this is an era of personalized immunosuppression, where you could do all of this before you transplant the organ, and that would allow you to have a better organ, and possibly in the long term, reduce, especially in the lung, instances like CLAD, or chronic lung allograft dysfunction, which is also known as bronchiolitis obliterans, or restrictive lung disease. So this is a facility out of Silver Spring in North Carolina, which is called Lung Bioengineering. It's a part of what the Toronto group has started. And what they do is they pick up extended criteria organs from all across the United States, bioengineer those lungs, and then give them back for usage. So you can take X-rays, you could do a pulmonary angiogram, you can do so much more with that lung under vision. We already have heard of HCV-positive hearts being utilized, especially in view of the opioid epidemic in the United States. You could treat those lungs with external beam therapy and probably even reutilize those lungs using energy devices. You can do immune cloaking, you can do cell therapy. The possibilities are unbelievable. Going forward, knowing that this is not just the new kid in the block, I think this therapy has come to stay. Using it as an immune regulatory tool, inducing tolerance, is something which is very exciting. The jury is still out on the long-term outcomes. As I said, we are not really very sure whether this technology will allow us to prevent chronic rejection, especially with lungs, or allograft vasculopathy with hearts. But we certainly know for sure that the short-term results are clearly very superior. I'll move on to xenotransplantation, and Churchill had a lovely quote that I'm sure many of you would have probably heard. Why pigs? So pigs seem to be the most acceptable source of organs for humans. And why are we looking at animals? Simply because we do not have as many organs as we require. The thing about pigs is they could be bred. Their size, it can be reasonably matched in young piglets. The anatomical fit is great. The physiological similarities with the human being make it the ideal species. And for various reasons, non-human primates cannot be utilized for organ transplantation in humans. But these organs can also be genetically manipulated. The problem, one of the problems with pig organs is endogenous retroviruses. They are a part of the pig DNA. So eliminating them, there's technology for that too. You can eliminate microorganisms from pigs by treating them with antibiotics, vaccinating them, weaning them from their mothers early on, preventing colostrum being transferred. You could do a cesarean section. You could also eliminate the porcine CMV by weaning the piglet off the mother very early, even if the mother is infected. Physiological considerations, very important when you're looking at pig as the source. Pigs are quadruped, humans are bipedal. Pigs have subhuman temperatures. They are hypothermic compared to humans. How does the heart or the lung behave in that environment? Pigs have cholesterol levels that are half of ours. How does that adapt to a human circulation? The growth hormone, we are not even sure how the growth hormone acts on the pig organ. The pig organ has a stiffer right ventricle. It doesn't accept volume loads really very well. So many physiological challenges. However, the most important challenge has been the presence of xenoantigens. I'm so sorry. The presence of xenoantigens, and the most famous one being called the alpha-gal. So the idea was to create, to reduce these xenoantigens in the pig endothelium. So they're called knockout pigs. So the first was removing the alpha-gal, which is an epitope on the pig endothelium. And human beings and non-human primates have antibodies already in their circulation. Though they do not have this antigen in them, they do have antibodies. That causes an intense reaction leading to hyperacute graft rejection. So knocking out the alpha-gal, knocking out the CMAH, which is new 5GC, that is another xenoepitope, B-fol-gal, NT2, are some of the knockouts. So not just 3 knockout, but 6 knockout gene pigs are now being bred in labs. Going forward, the other process of thrombosis in the native vasculature would have been the presence of pig complement. So this has been replaced by a humanized complement receptor protein. And multiple complement receptor protein like the deceleration factor alpha, CD46 have all been now added into the pig endothelium, creating a transgenic 6-gene knockout pig. Other strategies to prevent cellular rejections have been by using co-stimulation blockade. I'll talk about it a little later. Adding a humanized thrombomodulin into the pig endothelium, adding decay accelerating factors, and so on and so forth. Doing all of this brings us to a point where CRISPR, that is clustered regularly interspaced short palindromic repeats, the Cas9 system, allows you to edit the viral segments inside the pig's DNA that prevents zoonotic infections from coming into humans. So this is something that has been available now for us. So where have we reached now? We have reached a stage where a 6-gene knockout pig with multiple modifications, that's a transgenic pig, could be implanted in a non-human primate and survived for nearly 965 days. That's 3 years. Now that's remarkable. The only unfortunate part was in the abdominal position. So then they went on and implanted it in the chest, and it supported circulation for 195 days. So 4 of 6 pigs survived the experiment. So we're already at a stage where human trials can begin. And what were the other advances that happened? They realized that most of these pigs' ventricles would hypertrophy. So they needed blood pressure management. So telmisartan was utilized in non-human primates. They also realized that there was cellular hypertrophy. So that was controlled by the usage of an analog of sirolimus. It's called temsirolimus. So that allowed us to prevent all of these. So there are some remarkable advances happening. We're already at a stage where this is going to be a reality very soon. I hope it comes sooner than later. Going forward to 3D printed organs, we all know that if we look at 3D printed structures now, it's available all around us and doing remarkably well. So the time for 3D printed organs happens to be just around the corner largely, at least theoretically, simply because we know that tissue engineering has reached that stage in life. It's so evolved that we can start looking at a 3D printed heart. But what are the challenges? So you first need a scaffold, which is the skeleton, and then you need the cells. So how do you build a scaffold? So you can either decellularize a heart. You can strip off all the cells with a detergent by perfusing it. In a week, that heart would be ready. That's called an extracellular matrix. Or you could probably electrospin it, or you could probably utilize hybrid methods like having a partial human or a partial pig decellularized ECM along with electrospinning, which would add some synthetic material into it. So you could have that to create a skeleton, and that's what it looks like. And how do you do that? You do it with either cell-based approaches using multiphoton excitation lasers, or you could use a spheroid assembly. A bit technical, I won't go too far. But on the right-hand side, you would see a variety of cells that are possible to be generated in machines that are called cell factories. So this is how a cell factory looks like, and that's a cell factory. So it would help you manufacture up to 2 billion cardiomyocytes a week, and that would give you probably a few hundred billion cells in probably 6 to 8 weeks. But that's not easy. It's very expensive, but the therapy is there. The great part is all of these cells could be differentiated either into a nodal cell or a Purkinje cell, or even probably an endothelial cell. So there are nearly 40 varieties of cardiomyocytes that can be manufactured using cell factories. But here's the challenge. If it's plastic or metal, you can do it. When it's biologics, you can make it small, and you can make it complex, but you really can't make it big unless you make it simple. You can't build vascular networks yet. You cannot build thick structures, and organs, unfortunately, still not very feasible. And what do you need for that? You need a 365, 24/7, 365-day facility. It's very, very time-consuming. It's resource-intensive. You need scaffolds, which are not easily available. You need billions of cells. You need liters of media, few hundred liters of media, extremely expensive. You need bioreactors, because once you build all of this, you have to train that heart to function. And unless you train it, unless you give it physiological load, give it electrical stimulation, all those immature cells do not learn to function as one single unit. So and then you need tools to be able to validate all of this. But what you see is a cross-section of a heart. You see both the right and the left ventricle on a decellularized matrix, and it responds to circulating catecholamines. It even responds to pacing. So this is possible. We are already in the realm of possibility. So what do we do with this? We know that engineering customized hearts is not easy, but the best application to date is the roof of the urinary bladder and a segment of the liver. But the best applications which are currently in use continue to be bone and cartilage. So 3D printing is probably the future, but still a while away. I'll jump through some of them very quickly. I've spoken about this, but this is about scaffold decellularization and how to build a heart from a scaffold. So you take the heart from a donor after death, you decellularize it, you utilize cells from a donor. You take a segment of his skin as a biopsy, and you create iPS cells. They're cells that are pluripotent in nature, and they're induced pluripotent. So you can differentiate them into cardiomyocytes in a cell factory and then repopulate the decellularized matrix. And once you do that, you have a functioning heart. But it's not that easy because you have to strip away the right amount of material. You strip away too much of the skeleton, fibrous myoskeleton, you have a problem. It becomes immunogenic. If you strip too little away, then you have problems with rejection. What type of cells? We did mention. iPS cells are the best source. It's easy to build a few million cells, but the tune of a few billion cells is not that simple. But these cells sense their environment. They just don't sense factors. So how do you sense that? You can increase stiffness and mechanical stress by putting them in a bioreactor. So they have physiological load, and these cells learn to work together as one. What are the benefits? Because of all these technologies, now we are able to build bioengineered valves. We can have partial approaches or partial replacements. For example, for a hypoplastic left heart, you can build a ventricle. You can build scaffolds from cadavers. You could also have researchers understanding more about heart cells simply because the way they behave in 3 dimensions. But there are limitations. There are limitations that I spoke about in the past. But currently, we cannot build anything smaller than something that could support a rat heart for a very, very short period of time. I'll not go into the conclusion because we all know that tissue engineering, as we said earlier, has brought us to this phase. I'll try to quickly wind up with a few possibilities. A quick word about biological VADs. So we know the problem with mechanical circulatory support devices, especially the LVAD. You have strokes, GI bleeds, bloodstream infections, pump thrombosis, and you have driveline fractures, you have infections, and so on and so forth. You cannot redo surgery in a child with a VAD is difficult. You can't keep doing it time and time again. Patients get sensitized on VADs, leading to rejection when you transplant them. But the biological VAD replaces all these problems. And how do they do it? You have an acellular scaffold, which is basically made of chitosan and so on and so forth, and you endothelialize the inner lining, and you put in muscle cells on the external part, and then you start using it in a bioreactor, allowing it to learn to contract in a peristaltic fashion. Put in a valve, a unidirectional valve inside, and then what you have, an LV to apex conduit with a tubular graft with a unidirectional valve with contractile cells that synchronize their beats simply because they're trained to do so. It avoids immunosuppression, gives you a non-thrombogenic surface, allows growth potential in children. And the functional integration of these pumps with the host tissue is much easier. This is a schematic which shows you that. The remarkable advance has been sensor technology. So you can build sensors into this technology, like rising calcium gradients could be detected, and these pumps could be modulated. And all of this non-invasive assessment happens in real time. And all of these cells come out of cardiac progenitor cells, which I said come out from dermal fibroblasts. So the possibilities are immense, and the future is probably going to replace LVADs in a big way. Now, a quick word on immunosuppression and tolerance. We know that when we started lung transplantation 40 years ago, 30% of patients would survive in a year. And now 90% patients survive in a year. All of this is possible because incredible advances, not just in the understanding of transplantation, how adaptive and immune systems work, but also being able to control all of this. But when you look at the long term, even after 4 decades, we do not have more than a 50% survival at 5 years for lungs. Heart's definitely getting better. Why? Because the lung has a dual challenge. It's exposed to the atmosphere, it's also exposed to the human circulation. So immune recognition of the allograft antigen or a lack of response to it is largely a serendipitous process, or it could be acquired or induced by immunotherapy or pharmacotherapy. Lung transplantation stands to benefit immensely from all the advances that have happened in this field. So there are 5 of them, which I'll quickly go through. One of them is co-stimulation blockade. And what is co-stimulation blockade? The T cell detects the antigen, which is either on the surface of an antigen-presenting cell, and then mounts a response. It multiplies, it sends signals to B cells, they produce antibodies, so on and so forth. So there are receptor proteins on the APC, or the antigen-presenting cell, and on the T cell too. You have a mechanism of blocking that recognition pattern. So that's called co-stimulation blockade, induces energy, and there are drugs like abatacept and belatacept that allow you to have tacrolimus-free immunosuppression. This has a slightly higher incidence of acute rejection in most of these cases, but in the long term, if you can avoid tacrolimus, you can avoid any injury to the kidney, and obviously you can keep that patient going for long. Anti-cytokine therapy. There are drugs now that allow you to block cytokines. As you know, when the T cell detects an antigen, it circulates cytokines in the host, and which obviously start attracting other defense cells to go and attack the organ. So there's also advanced therapies for antibody-mediated rejection. We know plasmapheresis, we know IVIG, rituximab, which is a humanized monoclonal antibody. It acts like a medical splenectomy in patients who have had transplantations and continue to have antibody-mediated rejection. And then you have bortezomib, which is a plasma cell inhibitor. It's a proteasome inhibitor. It blocks plasma cell factories in big ways. We have tolerogenic dendritic cells. We have mesenchymal stem cells, which could be implanted into the organ, preventing trafficking, allowing better outcomes. And immunosuppression, as you know, in spite of the fact we have many unknowns related to the cellular and the molecular mechanisms that are involved in graft rejection, it's clear that a multitude of potential benefic therapeutic options continue to rise as this research goes on, and there's no reason to believe that at some point in time we will figure a way out and we will probably have organs living for longer time. A quick word on mobile health in transplantation. I thought it was very important. We all know that telemedicine works in various ways, but using it for organ transplantation is so important, largely in this era, because we've understood that affordable smartphones are there. We have expanding cellular networks and a disruption in the chronic care of patients post-transplantation. Mobile health is going to make a huge step forward. How? We all know that patients who need chronic care require to attend hospitals and outpatients more frequently than others because it's a chronic process. Now, we always have barriers to it. We have cost constraints, we have who's going to be the payer, we don't have, in a country like us, we definitely have accessibility issues, overcrowding, so on and so forth. So these being the areas of focus, it's important to understand that we can manage wait lists better using mHealth. We could help teams collaborate between both the donor and the recipient team. We can utilize that information to be able to make better understanding. You can use artificial intelligence in many ways. We could talk about donor advocacy, and in the end, we can not just manage the education of these patients in the long term. We could also have adherence to drug therapy, where you could have a medication tray with a timestamp or an automated alert. You could have trend analysis for organ function. Patients after a lung transplant, you could continuously monitor their FEV1s, their VO2 maxes, utilize biomarkers, and give them great care. So in conclusion, the future of organ transplantation and their care definitely lies in the hands of mobile health. It's only for us to understand it better and effectively deploy it. I will end by saying when you look at the possibilities instead of the problems, the future is filled with endless possibilities. I thank you for your time and your patience. I'm sorry I just